Hello, dear students. Today we will discuss about the selection of the P drug for thyroid disorders. Now we all know that thyroid gland, which is situated in the neck, and it performs very vital functions in our body and almost each and every organ and the system. For their proper functioning, the normal thyroid hormone level is essential. So, the learning objectives of the today's sessions are: students should know the different types of thyroid disorder, and students should able to select the P drug for these conditions. Now, which are the different types of the thyroid disorder? Either the thyroid hormone level is low, that is hypothyroidism, or it is high, that is hyperthyroidism. In hypothyroidism, again, if it is a congenital or seen in infants, it is known as a cretinism, or in the adult, it is a myxedema. If it is an emergency condition or crisis, it is known as a myxedema coma. While in the hyperthyroidism, either it is idiopathic or it is immune basis, or there is an emergency condition which is called thyrotoxic crisis. And there are certain other thyroid disorders that belongs to thyroid carcinoma, but today we will discuss about the P drug for hypothyroidism and hyperthyroidism. So we start with the first case, and before going to that, just quickly revise the steps for the selection of the P drug, that is, identify the problem, define the therapeutic objectives, then list of the effective drug groups for that condition. Out of these drug groups, which is the most effective drug group? Then among this drug in this drug group, which is the most suitable agent? And then finally the prescription. So now our case first, that is a 30 years old female patient complains of fatigue, cold intolerance, mental slowness, dry skin, constipation, muscle aches, and irregular menses for past 2 months. On clinical examination, she has bradycardia, delayed relaxation phase of deep tendon reflexes, and hypotension. Investigation shows decreased serum T3 and T4 level, and the diagnosis is hypothyroidism. Many times the serum T3 and T4 levels are normal, but the TSH level is raised. So I want to convey that all the levels T3, T4 as well as TSH levels are essential to come to the conclusion of thyroid disorder. But here our aim is to discuss about the P drug. So the first step is identify the problem. What is the problem? The problem is hypothyroidism. Now therapeutic objectives. What are the therapeutic objectives? First and foremost objective is we have to restore the thyroid hormone level to the normal, and not only that, but we have to maintain that euthyroid state continuously lifelong. And if we can identify any underlying disease or cause, like if there is any pituitary lesion or hypothalamic lesion or autoimmune disease, then if possible to treat it. And lastly, patient education. Patient has to be explained about the condition that he is having, then what is the importance of the drug therapy, what can be the consequences if the patient is not taking the drug regularly. So the importance of the drug therapy, this will help in the patient compliance, and patient has to be clearly explained in an sympathetic way that patient has to take this drug therapy lifelong. Okay. So which are the effective drug groups? It is very obvious that patient is having hypothyroidism, so you have to supply the thyroid hormone from the outside. Now there are two hormones that are available, there are T3 and T4, and So the thyroid hormone replacement therapy is essential. Now, as such that we will select out of these two agents in the next slide, but regarding the thyroid hormone replacement therapy, in the initial phase one has to start with the low dose, and in the initial phase frequent follow-up, frequent monitoring and frequent thyroid hormone level T3, T4 and TSH measurement is essential to titrate the dose. And the only limiting feature is that if any higher dose or excessive dose given or the rapid tapering of the dose has been done, then there are chances of overstimulation of the heart, and this can lead to the precipitation of the angina, myocardial infarction or heart failure. So one should be very cautious while prescribing the thyroid replacement therapy in a patient having cardiovascular illness. Otherwise this treatment is safe, and there are chances of allergic or idiosyncratic reaction with the animal derived product, but as these products are not used nowadays, so there is no question about the discussion of this issue. So now the question lies in the selection between levothyroxine and liothyronine. Now we all know that T4 is a circulating hormone and T3 is an active hormone. In the periphery, the T4 is converted into the T3, and all the pharmacological actions of the thyroid is due to this T3. But there are certain differences or there are certain concerns before the selection of the agent. And first and foremost is that levothyroxine is chemically more stable. Second thing is that it is tightly bound to the plasma protein, and that's why it is having a longer duration of action, and hence single daily dose is sufficient. As compared to the liothyronine, it is having a very short duration of action, and that's why frequent daily dosages are required. And even after this, there are fluctuations in the level of the plasma thyroid hormone level. No doubt that T3 is having a rapid onset of action as compared to the T4, and which is desired many times in the emergency conditions, say for example the myxedema coma, but it is not required in the present case. That is one. And second, most important thing is that even in the emergency condition, nowadays the T3 or the liothyronine is not preferred because of its cardiac adverse effects. Why? Because the liothyronine sensitizes the heart to the arrhythmogenic action of the adrenaline, and it will lead to the development of cardiac arrhythmias, especially the atrial flutter and the fibrillation. And because of this potentially serious adverse drug reaction, now even for the myxedema coma, levothyroxine is preferred. So in the prescription, tablet levothyroxine, always one has to start, as I told you, that start low and go slow in the replacement therapy, okay, because it is not an emergency condition. And if the patient is having cardiovascular disease, you have to start with the 25 microgram, else you may start with the 50 microgram and dispense such 15 tablets, one tablet to be taken daily in the morning. And in the initial case, as I told you, the dosage titration will be done according to the response of the patient, their biochemical markers, and that's why initial frequent follow-up is required, and that's why patients should be asked for the follow-up after 15 days. Now here, even though the heading is prescription, but I have only mentioned the drug and its dosage regime. But in the exam you should write all the parts of the prescription, and that are superscription, inscription, subscription, transcription and signature. So this is all about the hypothyroidism. Now the next is a case of hyperthyroidism. A 28 years old female patient complains of palpitation, increased motor activity, intolerance to heat, frequent motions and weight loss in spite of increased appetite for past 2 months. Clinical examination reveals flushed and warm skin, tachycardia, pounding arterial pulse, and exophthalmos. Investigation shows elevated serum T3 and T4 levels and reduced TSH levels. The diagnosis is hyperthyroidism and you have to prescribe drug therapy for this patient. Now, what is the problem? The problem is the hyperthyroidism. And what are the therapeutic objectives? Obviously, that one has to restore the thyroid hormone level from the higher range to the normal level, and not only to restore but maintain the euthyroid state without any significant adverse effect and without frequent changing in the therapy, and if possible one has to identify the underlying disease or the cause if any there and treat it if possible. So now effective treatment modalities. Now here I have not used the drug groups. The reason is that there are 3 different treatment modalities are available. So it is a different scenario, like the oral antithyroid drugs are available, then radioactive iodine is also available, and surgery is also available. Now each of these 3 treatment modalities, they are having their own advantages and disadvantages. If we consider the last one, the surgery, it is a definitive therapy, so there is a no recurrence, but at the same time there is a permanent hypothyroidism will be there. There may be hypoparathyroidism is also there if the simultaneously parathyroid gland is also removed. Now the surgery is also not possible in an old age or even in the middle age if the person is having significant comorbid condition. Okay, and surgery is technically difficult into the pediatric age group. But at the same time, if there is a recurrence of the disease even after the oral antithyroid drug, or many times even after the radioactive iodine, or the patient is having a diffuse toxic nodular goiter, or if you cannot rule out the thyroid carcinoma, in all this case surgery is the treatment of choice. While in case of radioactive iodine, when, because it is a single or at the time 2 dose therapy, it is an outpatient procedure. Here patient will not have to undergo the surgery and related complications. Okay, and patient will not have to take the drug lifelong, but at the same time there are chances of recurrence, that is one. But even more important is that this cannot be used in the pediatric age group because of the permanent hypothyroidism and in the pregnancy. That is the second case. Okay, now about the oral antithyroid agents. If a newly diagnosed case is there, one has to start with the oral antidiabetic agents, and if at all the patient is not able to tolerate this antithyroid drug, which is very rare, or if the thyroid level is not controlled with the oral antithyroid drug, then one has to think about the radioactive iodine or the surgery according to the patient profile. But here if you just think that patient is a 28 years old female, okay, and it is she is yet not pregnant, no mention about the pregnancy is there, okay, that is fine, but it is an young adult female, so we should not think about the radioactive iodine. Second is that surgery, so newly diagnosed case, okay, so there is no question of the surgery at all. And again I am repeating the same word, in the newly diagnosed case one has to think about the oral antithyroid agent. Now if in the same case, if a female is around 40 years or 45 years of age and she is a known case of hyperthyroidism and not controlled with the oral antidiabetic drugs, then one can think of radioactive iodine also. But in this case, as the female is having a childbearing age, newly detected case, no history of recurrence, and that's why the treatment modality is oral antithyroid agents. Okay, now you have to select amongst the oral antithyroid agents. Now which are the oral antithyroid agents? Ionic inhibitors. Now I want to say that potassium thiocyanate, potassium perchlorate, these agents are there, but they just remain in the classification. Now they are not used at all clinically because of their potentially serious adverse effects, and we are having a better choice of drugs are available. Fine. So the another is iodides. Now iodides, they are very useful. You know that the iodides are the most rapidly acting antithyroid drugs, and their response is exactly similar to that of the surgery or even the radioactive surgery. Okay, because they act by inhibiting the release of the thyroid hormone from the thyroid gland. So if you want rapid control of the hyperthyroidism in case of the emergency, iodides are the drug of choice. Iodides also makes the gland less vascular and firm, so preoperatively they are the drug of choice. But here the case is different. Here we require long-term control, and for that, because of the problem of the thyroid escape, thyroid constipation and allergic reactions, iodides are not preferred. Then the other agents are beta blockers and corticosteroids. They are we can say that the life-saving drug as far as the crisis is concerned, because they inhibit the peripheral conversion of T4 to T3, and additionally beta blockers, they control the sympathetic overactivity, and because of this there is an excessive cardiac stimulation. But they can be used only in the emergency. They cannot be used for the long-term management. So the last group, that is thioamides, they are orally effective, they are efficacious, even though they are having relatively slower onset of action as compared to the iodides, but they can be used for the long-term control. So here in this case, the preferred drug group is thioamides. Now which are the agents in the thioamides? There are propyl thiouracil, carbimazole and methimazole. Methimazole is the active metabolite of carbimazole. That's why we have to select between the two agents, that is carbimazole and propyl thiouracil. Carbimazole, it acts as an level of the enzymatic inhibition and inhibits the thyroid hormone synthesis. It also inhibits the coupling also. But the differentiating feature from the propyl thiouracil is that it is having relatively longer duration of action as compared to propyl thiouracil. I am very intentionally using this word relatively, because the propyl thiouracil has to be taken 3 to 4 times a day, while carbimazole can be taken once or twice a day. The second difference is that carbimazole is relatively cheap as compared to the propyl thiouracil, and here cost is a major determinant factor because the treatment has to be continued lifelong. Now what are the characteristics of the propyl thiouracil? All the mechanisms of the antithyroid action is there of carbimazole is seen with the propyl thiouracil. Additionally, it inhibits the peripheral conversion of the T4 to T3, but it is required when you want the emergent control of the symptoms, and it is again a very safe during the pregnancy. So here again our aim is not the emergency condition, not the pregnancy, okay, and that's why for the long-term control we have to go for the carbimazole because of the its relatively longer duration of the action, and it is cheap as compared to propyl thiouracil. So in the prescription, tablet carbimazole 5 mg, dispense such 15 tablets, 1 tablet to be taken daily in the morning. It can be prescribed like that, 1 tablet in the morning and 1 tablet in the evening. And as I am telling you that in the initial case, the dose titration is most important, and that's why the initial frequent follow-up, and based on the patient's response and the biochemical markers, one will decide the final dosage regime, and that's why initial follow-up after 15 days. So this is all about The hyperthyroidism, we have discussed two cases, hypothyroidism and hyperthyroidism. Again I am repeating the selection of the treatment modality. In the hyperthyroidism, it will depends on the many factors like it is a new case or a recurrent case, patient is having a allergic or other adverse effects to the antithyroid drug. If it is a recurrence with the oral antithyroid drugs, there are contraindication of the radioactive iodine, contraindications for the surgery. All this will decide the treatment line. Okay, so this is all about the P drugs for thyroid disorders. If you like these lectures and practical classes of the pharmacology, then you please subscribe this channel, that is Pharmacology in the Simplified Way by Dr. Darshan Dave. And if you are having any questions, you can ask in the comment box. Thanks a lot. Keep sharing and keep learning.